Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Dr. James Thomas. He's an associate professor in the Department of Epidemiology at University of North Carolina at Chapel Hill. He's working on the public health effects, the ethics of coronavirus, SARS-CoV-2 or COVID. He has an interest in complex systems and studying them and modeling them and doing network analysis. And, we'll get into his research. So, Dr. Thomas, thanks for coming. How you doing?
I'm doing well. Good to talk to you.
So what was your typical course of research until the recent coronavirus outbreak, and how has it changed since the outbreak?
Well, my typical line of research is looking at social determinants of infectious diseases. For example, I spent some time looking at the effects of mass incarceration on communities and how that affects mostly those left behind. There are others who are studying the people who are in prison, but I was studying the communities that they were taken from, and how mass incarceration affected those and increased teen births, increased sexually transmitted diseases, and some other things. And I was also doing a lot of work in developing countries with their health information systems. And for the last 10 years, I've been working all around the world and developing those systems, and was beginning to get into the ethics of digital data and how they are used in public health. This was stemming from my work with health information systems. And then COVID happened. And with COVID, I was pulled back into an area of research where I had worked before.
When you say mass incarceration, I mean, what form did that take previously? Like, why would there be? Was there mass incarceration because of an outbreak, or it was just?
No, it was you could say because of an outbreak. It was the war on drugs, and so it was the cocaine epidemic, and the U.S. Their primary way of fighting the cocaine epidemic was imprisonment, and the U.S., because they were putting in prison so many people, either users or sellers, we ended up with the highest rate of incarceration of any country in the world. So I had been working in communities with a high proportion of African Americans, and they were more affected by the war on drugs than whites were because, just a number of things. But one that's often cited is that the type of cocaine used by African Americans got a different sentence than the type of cocaine used by whites. And it was about a 10-fold difference in sentencing. And so the number of African Americans in prison just exploded. And there were communities that I was working in where you could walk down the street and look at any given house, and it had been touched by incarceration in some way. Either somebody was in prison or had just gotten out or was in jail and ready for trial. So it was a massive effect on some communities.
With the coronavirus, I mean, would you consider the lockdowns to be mass incarceration worldwide? Are there any similarities?
That's an interesting way of putting it. I guess the first thing that I would think about is those who are incarcerated actually in the prisons and how they are affected by coronavirus and how they can't run away from it. They can't become isolated. Now, there are some steps that states and cities have taken to release people, to put them on house arrest, to put the ankle bracelets on them and get them out of the prison where they're just a sitting duck. But to your point of the incarceration of the population, that's not a term I would use for the population. With our ability to get out and move around, just this weekend, I got in my car, I drove out into the country, I found an isolated country road, and I took a walk on that road. Didn't encounter anybody, but I had the freedom to do that. So I would not call my isolation a type of incarceration.
Yeah, I mean, well, just for listeners, this is totally my thought. It's not yours. I'm not saying it's yours at all. I think it is. It seems to me like, a lot of the world is a jail, and I'm very thankful I live in the U.S. because in other countries, it does seem to me that, in some countries, people appear to be beaten if they go outside and forced to stay home. And even if you looked at it as a voluntary thing and people were staying inside a house for weeks on end, I mean, I guess you can even call it self-incarceration, or whatever you want to call it. But, what is the effects of that? Are you looking at that at all? Or is that really too far afield of what you normally look at?
No, it's not too far afield. You're touching on some things that I do think about. Now, certainly there are countries where house arrest is common, and where some authoritarian governments where there's a high level of control. We might talk about the Uyghurs in the western portion of China and the incarceration or the camps that they have been put in by the tens of thousands. So one could look at that, or one could look at how an authoritarian government's surveillance is moving, in part because of COVID, moving in the direction of digital surveillance. There are examples in China of the use of drones with cameras that are able to measure the heat of subjects on the ground, and using that to determine if somebody has a fever and has left their house and should be back in their house. We are talking here, and other countries are, of using cell phone GPS data to monitor where people are, and if it's known that they are infected, to take some measures to get them back in their houses. So there is a level of, I'm still going to avoid the word incarceration, but I'm going to use coercion. There is still a level of coercion. It varies by government, it varies by country, but there is an element of that in public health, and that's one of the ways that public health ethics differs from medical ethics, because in medicine there's a very strong emphasis given to autonomy, and the autonomy is raised to the top, or to a top level, because of the abuses that a physician or a clinician can have over a patient. And so to protect the patient, we say that person's autonomy is very important. They have the ability to say, no, I don't want to take that step. I don't want to take that pill. In public health, where especially you see this with infectious diseases, one person's infection is another person's exposure. And if you don't constrain the autonomy of some individuals, they will infect others. And so for the good of the greater community, some people will have to stay inside, and particularly those known to be infected. So there is a greater level of constraining of civil liberties in some instances in public health than you see in medical ethics.
So, I mean, do you have any, from your past experience, do you have any guidance? I know it's up to, individual countries and the U.S., individual states, and et cetera, the guidance. Really, I really see no guidance. It's all over the place. But I don't know. Do you have any guidance based on your past experience?
Yes. Yeah, I do. So there is a set of principles that were developed in a city called Siracusa. They're called the Siracusa Principles. And one of them, these are instances of, or what needs to be considered when constraining civil liberties. And one of those principles is that you use the least restrictive, effective measure. So in the case of social isolation, for example, then you look to constrain people as little as possible while having the needed effect to protect the health of the public. And that allows you to titrate, if you will, the amount of constraint that is used, whether in some countries They will have police giving fines to people who are found outside. In other countries, they don't do that. So they will vary to some degree in how much constriction they are going to enforce. Now, one of the challenges with COVID is that the incubation period is taken to be somewhere in the vicinity of 2 weeks, or at least we allow for 2 weeks for incubation to occur. And so the actions that are taken, if you're wanting to judge effectiveness, you don't see it until 2 weeks later. So the steps that we are taking today will be able to judge 2 weeks from now. The steps that we took 2 weeks ago, we're finally able to judge today. And that makes some of the ethical decision making really challenging because you don't want to overshoot, you don't want to overconstrain, but you don't know yet what's going to be effective. And that's particularly true with COVID, where we know so little about the biology of this organism and its infectiousness. And we're learning some of these things now. We've been in it for a while now, but initially we didn't know what level of infectiousness to assign it. We didn't know what proportion of people were asymptomatic. We didn't know how long the organism lived on surfaces and whether, even if it did live, was it infectious? So many questions of things that we don't know about this virus that would help us make these decisions and help us to toe an ethical line.
Do you think that information is, even if it's known, is it being communicated? Or, based on the reactions, for instance, of governors around the USA, which are all different, completely different, do you think it's being listened to? I mean, what's your read on what's going on?
Boy, this, probably the chief ethical mishap of this epidemic has been the confusion in the communication. It has not been clear. We get different voices, and depending on our politics, in the contemporary world, people tend to sort themselves out by politics, and what they listen to gets sorted out along with it. So we will have 10 voices speaking about COVID and steps that need to be taken and steps that cities need to take. And each person is going to listen to their own chosen voice. And it's harder to listen to a single voice. So we've got Anthony Fauci saying one thing, we've got Donald Trump saying another, we've got Governor Cuomo saying a third. So it's very challenging. It's very challenging for us to work together. It's often said we're all in this together, but there are elements of what we are doing where we are not. We are not working together in the ways that we could or should.
Well, so I guess. What are your thoughts on what's likely to happen from here over the next, I don't know, we'll take it bit by bit, next month, next 3 months, next 6 months.
Yeah.
Based on your past experience, what do you see happening probabilistically?
So one of the tragedies of public health ethics is that very little of it is done in advance of the ethical issue. It tends to be clarified and codified after a major mistake. Take the Tuskegee syphilis study, for example, where this occurred in the, I think the 30s, 40s, and up through the 70s, early 70s in Alabama, where uneducated Black men with syphilis were enrolled in a natural history study to see what happens with untreated syphilis. And it started at a time when there was no treatment for syphilis, but shortly after, or maybe it was even during World War II, a treatment was found, but actively withheld from these men. It was eventually revealed, eventually stopped, and following that, we moved into what we now recognize as much of our research ethics at universities and elsewhere. It was a result in large part because of this injustice that occurred through a study. So now bringing that back home to COVID, if we're going to follow that same pattern, it's likely that we are going to get, let's say, slapped in the face by some things that we see that become clearly unethical. They become clearly unjust. And as we recoil from that, then we'll begin to think about what should we do differently? What's going to have to change so we don't do that again? Now, one of the things in the closer horizon that I see happening is the easing up of the social isolation. The isolation is not anything that any of us enjoys and any of us wants to prolong any longer than it needs to. But as we see that being lessened or loosened in some states, then people are interacting more and transmission will occur. It's just a biological fact. It's going to happen. We will have more cases and we'll have more deaths, and they could be quite striking in numbers. And from what I read this morning in one of the newspapers I read, apparently we're already seeing a rise in cases in some of these places where people are interacting more. So we're likely to see rises in cases and deaths, and maybe a reaction to that and saying, okay, everybody run back home and stay away and stay out of public spaces for a while until things calm down again. And then people will get quarantined.
Wouldn't it just keep happening? It doesn't seem like we're ever going to get rid of this virus. And,
yeah, it does. It seems like, it could be like a sawtooth ending to the epidemic of it going up and down. And what has happened with epidemics in the past is oftentimes, the organism changes on its own and becomes less virulent. That's something that could happen. We could get this magical vaccine, and let's just say it's an effective one and it comes soon, and that could change things. We could get an antiviral medication that could make death less likely. That would have a big effect. So there are things that can happen that will change the course, but you're right. It does seem to be quite long lasting.
Well, also too, the news is, the media has frightened everyone to death, literally. And, they make statements that just are ridiculous. More people are going to die. Well, unless people undie and come back from the dead, yes, more people are going to die. But percentage-wise, is that a lot? Is that a little? Is that acceptable? If you look at also the backdrop of approximately 7,500 people in the U.S. die every day of all causes, that's not mentioned. And, those lives never seem to be cared about for the most part. Mm-hmm. So it's just the dynamics just seem to make no sense. I don't know. It's just I just don't know how this is going to resolve when the facts, or I don't even know if you call them, I don't know what you call them, facts, or they can be interpreted any which way, it seems like.
Part of the problem is that this is a disease that is affecting wealthier people, and it affects the poor more. I don't want to neglect that point, but it's affecting all strata of society, and so there's a bigger reaction. Now, when I started in public health, I started in the Congo. It was called Zaire at the time, and I was focusing on starvation. And soon after that, I was working in Kenya on diarrheal disease. And at that time, those two conditions, malnutrition, starvation, diarrheal disease, were the major killers worldwide. And we tend to forget those things. We've gotten numb or accustomed to certain causes of death, particularly when they affect populations that we're not part of. The people in the villages of the Congo that most of us never see. So you're right. There's a lot of deaths that we just ignore or accept.
Yeah, that's why some of these assertions, again, I don't know if this is true or not, but, people couldn't get what was called elective surgery, and some of that's for cancer, for organ transplants. People couldn't do regular checkups. I'm one of them, for cancer and stuff. So it's just crazy. oh, if you die of coronavirus, okay, that's bad. But anything else, who cares? No big deal.
Yeah.
You know, it just doesn't
I
make
hear
any
you.
sense, and I just don't know what. I don't know. I'm not sure what's going to happen. That's why I guess have you studied even localized, not pandemics, but epidemics like this, and in terms of behavior of people, what have you observed, and are there any learnings from that?
Well, yes, I have. And soon after I got my PhD at UCLA ages ago now, I worked for the Los Angeles County Health Department doing outbreak investigations and did that for about 3 years. And one of the things that I noticed was that when somebody else, when you see somebody else getting sick, people would report that these occurrences of their colleagues are getting sick, and they would report it as, a cluster of cases or an outbreak. But when they were part of it themselves, all of a sudden it was an epidemic, and it rose to a higher level of importance. So I have seen pretty consistently that when something is experienced by somebody, that they tend to elevate it, but they also tend to focus on that one thing and become a bit with tunnel vision to focus on that one thing and neglect the others. So I see that happening some with COVID. I've seen it happen with other epidemics.
So does this give you any idea on, again, so we spoke about this partially already, as things open up, we're going to see an increase in cases, whether that's characterized as too much or not. I don't know. It depends who's speaking and who's listening. There's no doubt about that. We're going to see an increase. It's not going to happen. But what do you think? How do you think this is going to play out, or it's anyone's guess? Do you feel like you have any insight into what may happen, or to say wouldn't be any better than anyone else's guess?
I wish I had the wisdom to see clearly what's coming around the corner, but so some of the modelers, the mathematical modelers that are looking at the epidemic and the projections of what's going to be happening, they base their models on different kinds of questions and different kinds of data. The Institute for Health Metrics and Evaluation, IHME in Seattle, they tend to use data from other countries, like from China or Italy, and to look at the experience of what has happened there, and then base their own models on their own American models on those kinds of data. Others will take, some of my colleagues locally here are asking a different question, not what's going to happen, but the question, or the number of cases and what the epidemic curve is going to look like. But the question they are asking is, when will our hospitals be overwhelmed? When will we be turning people away from ventilators or beds? And I'm in North Carolina, and we recently shifted to a slightly less severe social distancing, which we call phase 1. And it's a modest move, but it's a move in the direction of easing up social distancing. And from what I can tell, the modeling that supports that move is based on the projection that we've got room in our ICUs and our ERs for more people. So it's not that the epidemic is over, but if the whole purpose of isolation is to flatten the curve, it's not to bring the curve to zero, but just to space it out so that we don't overwhelm the ERs and the ICUs. So that's probably the way that we're going to manage it, is we're going to try to pace the severe cases as best we can, not try to avoid them altogether.
Yeah, no, that's true. Is that being communicated? If it's not, then what are people supposed to do with the information that, again, is put out? Oh, the number of cases are going to rise. More people are going to die. That's used it's just used as a scare tactic. So why? I just don't understand. Why is there no guidance? I don't even hear it from one person. Much like you said, there's a lot of people talking, Fauci, et cetera. I'm not hearing it from anybody. Any numbers, any guidance, are they just politically unable to give any because they would be like vilified? One life is too much. type stuff? Or, I mean, and so what do you do then? If we're all a bucket of crabs and a crab tries to climb out and the other crabs pull it back in, which is what seems to be happening, then what do we do? How do you fix this?
Well, you're asking questions bigger than I am, Richard. But what I have noticed is that so we have voices that are more scientific and we have voices that are more political. But even some of the political ones are listening to the scientists and echoing what they are saying. So I think that the large majority of the public is able to discern the kinds of steps that should be taken, the kinds of steps they can take. And oftentimes there is a greater caution on the part of some than what the governor would have them do, for example. So there is that, but will that protect us from the other element of the population that is ready to run out of their house into a party or into a mall, and the number of cases that will occur because of that? That won't be contained to just those people who get out. It will filter back to those who are socially isolated. That's part of the challenge that we face. To your point of, is anybody saying it's not a matter of trying to keep cases as low as possible, it's a matter of pacing our resources? I'd have to agree with you there. I don't hear that being said, perhaps because it doesn't feel compassionate, but I think it's a reality, and it's consistent with the initial message of flattening the curve, isn't it? It's we wanted to minimize that upper part of the curve that was so far above what our hospitals were able to manage, and we have found with experience that the social isolation does achieve that. And from the things we have learned about the virus since then, we have seen that social isolation actually does a fair amount. And now, as we are correcting, we're going to get a natural experiment, if you will, able to look across cities and states to see how much is too much loosening up and how much is appropriate. It gets back to that. I'm sorry to interrupt. It gets back to that question of the least restrictive, effective measure, and maybe it's the flip side of that. It's what would be the flip side of that? I want to say the least liberal, or the least that word gets confused these days. The amount of the correct amount of freedom that doesn't send huge numbers of people into the hospital.
Yeah, I mean, again, maybe this is glib, maybe not, but auto accidents, let's say, cause, 20, 30, 50,000 deaths a year. Mm-hmm. Why are those deaths acceptable? Why are we allowed to drive cars?
Yeah,
why
because
why are those lives important?
Yeah, we've become numb to that, and we've come to accept it as part of everyday life. And that's part of the normal we want to get back to.
Right. Like even look at a better corollary. How about flu? In the U.S., the CDC themselves say 30 to 50, 60,000 people a year die of flu in the U.S. alone. Why is that? No one cares about. Who cares? It's totally fine. No one blinks an eye.
Well,
why
COVID,
this? How do you put this in context? Since the models appear to be very wrong, at least so far, and the deaths are what they are over this time period, but why is there no analysis? Okay, we thought this would happen. So far, it hasn't happened. So this is the plan going forward. Again, there's no feedback in this. There's no reasoning. There's no logic. There's no guidance.
I wouldn't go quite that far. We do see at state levels and even at the national level an articulation of the kinds of things that we want to see as we move to lessen the social isolation. We want to see the number of deaths on the downside. We want to see the number of hospitalizations going down for a couple of weeks. So there are these metrics that are given that we are looking for so that we know when we can loosen things up. And that that is what's occurring in my state. The rationale given for taking the steps that it did just a couple of days ago was the data of what they were observing in trends of cases in North Carolina. And then they took the step to loosen things up a bit.
Well, I mean, I would think that all states would be aware of this, and maybe some are using others as experimentation. Maybe not. I don't know. So I guess it's just a mixed pot. And,
most states are aware of these kinds of metrics and ways of pacing things. Not all of them are following it. They have different impulses of how they want to go about it. And I believe that we probably are headed into a natural experiment where we can see where things are going to be enough and where they're going to be too much.
Okay. So what, we're pretty much at the end. I hope I haven't driven you nuts with my questions, but what guidance do you have for people based on what they're looking to figure out about, the current coronavirus pandemic? What guidance would you have for people? Where can they go? What are some things that would help them think about what's going on and maybe how their own behavior should change or not change? Do you have any recommendations?
Well, so you're probably referring to people who are, let's just say, residents of the country. There are places they can go. I'm finding that the Centers for Disease Control has good advice on its website that guides individuals on the kinds of steps that they can take. It has good advice on masks, for example. And then for the professionals and the policymakers, I have developed a website called Pandemic Ethics, which shows the policymakers what ethical steps they can take to set policies for a city or a town or a state. But again, your listeners are probably more likely to be those who are residents, and I would point them to the Centers for Disease Control. Okay.
Well, very good. Well, James, thanks for coming on the podcast, and I appreciate all your advice and and thoughts.
You're welcome. It was a good, lively conversation. I appreciate it.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.